It's great to see everybody after a bit of a hiatus. We've been sort of having to rearrange some stuff with the end of the grant that was supporting MASEC work, but I think we've gotten things straightened out now, and hopefully this will be continuing on at a sort of slightly slower but regular tempo going forwards. Um, we are waiting for our speaker to come on the line, Katharine Nehme. Uh, Hold on a sec. I am dealing with a bit of an emergency, so Aaron will be leading uh, the session for a little bit, and then hopefully things get started relatively soon. Great seeing everybody again. I'm glad we have such good attendance.
Yes, thanks, Kevin. As soon as Dr. Nami gets here, we can go ahead and get started.
Muted. Hello, Erin. Sorry, I was running late in clinic.
Oh, that's
Sorry
okay.
about that for everybody.
It's great to see you. I'll just introduce you real quick, everyone, and correct me if I don't say your name right. This is Catherine, Dr. Catherine Nami. Is that correct?
Yes, that's right.
Yes, perfect. And she is an assistant professor in the Department of Internal Medicine at Washington University in the Division of Allergy and Immunology. And she has agreed to speak to our MASA group today about an update on beta lactam allergies, which we're all very excited to hear about. So thank you so much. Good to see you.
Good to see you too. Nice to meet you over video and lovely to meet everyone today. I have to say, this is an area that I am really, really excited about and always very happy to share information along the way. I'm trying to make this talk as interactive as possible as we can over Zoom. So I'm going to try something out called Mentimeter, which is where if you can use your smartphones to scan into a QR code, there'll be a couple questions throughout.
Ooh,
So let's see if it all works. Oh, I think, let's see. For sharing, maybe it doesn't recognize.
I think you should have access. I just clicked on multiple participants can share, so.
Ah, thank you. Perfect. Great. So you should see yourselves reflected back at me. And then just to make sure, can you see my PowerPoint? And then
Yes, that's coming through.
perfect. And I also want to make sure I can pop over here to my other screen along the way. Okay, perfect. So you should see my other screen. There's a question up there right now. Is that correct for
Yep.
everybody? Great. Thanks for letting me do that little test. So again, I'm always super duper excited to talk about this topic. To me, it is such an important population health investment of all of our times to learn a little bit more and for me to be able to share with you all as well. So I'll talk through my goals for today. I'd like to share how can beta-lactam allergies be removed and how can that really, really help your patients? And then who is best situated to address these allergies? what next steps can be taken once you do an assessment, and for which reactions and cross-reactivities should you keep an eye out and be more cautious. So trying to keep this as practical as possible. And I also want to let you know I welcome questions throughout the whole talk, trying to make it as interactive as we can over Zoom, and as virtual participation is great. So I'd love if you could try to scan in here to this QR code, because I'd love to hear a little bit more about what you've experienced recently for your allergy experiences. So I'll let that sit up for about a couple more seconds while you scan the QR code. It's a little bit easier to use your phones and scan. Another option is to type in the code over here. And I'll give you about one more minute to scan in here, and then I'll pop over to that other slide.
Katie, it worked fine for me.
Awesome. Great. So we're going to start seeing some pop up. Oh, I'm happy to see that it's a lot of penicillins, cephalosporins, and it makes me glad to see along the way too that penicillin is probably the most representative historically speaking. I think you heard a couple years ago from Jen Monroy, who did an excellent job really talking through the background of why penicillin was so allergenic initially. Beta-lactam allergy, that's great. And then keeping moving forward, how recently have you had to alter your treatment plans due to a drug allergy? Oh, great. Okay. So that's good for me to know. I know it's common, but we don't get to hear everything along the way as allergists. We see a lot of the severe stuff. So it's really interesting to be able to see that so many of you are really changing your plans and on a regular basis too. All right, so I'll hop back into my slideshow along the way. You already see this, you're on the front lines. Penicillin allergies are very, very prevalent. 1 in 10 people will report it, and that number goes up to 15% of hospitalized patients. So the more regularly we have healthcare involvement, the more often that we're going to see people reporting this allergy. Interestingly, cephalosporin allergy is also growing. 1% of the US population will report a cephalosporin allergy. And it might be a little bit higher in hospitalized patients too, just due to their exposure. But the most important part is to realize that 9 out of 10 penicillin allergic people are not truly allergic. And as we get 5 to 10 years out from a true IgE mediated, so that immediate hives and swelling type of reaction or passing out and vomiting, 70 to 90%, about 80% of people will lose that sensitivity. The cells that produce that antibody are just not supported if there isn't continued exposure. So why does this matter for our patient outcomes? Penicillin allergy resulted in a 3 times increased risk of adverse events during medical encounters. Readmitted for the same infection, antimicrobial treatment failure, C. diff, MRSA infections, or drug-related adverse events. So the medications we're choosing the second line have more side effects. Also, surgical site infections are more common in penicillin allergic patients. So the alternatives are associated with decreased efficacy, longer hospital stay, higher costs for patients and the healthcare system. And this continues to hold up over time. There was a 2020 study of 438 patients who were admitted with sepsis in central Kentucky, and they reported a beta-lactam allergy. And they had a longer time to initiating antibiotics compared to their non-beta allergenic peers. It was a delay in almost 2 hours, so about an hour and a half delay, and an increased risk of inappropriate coverage by 20%. Overall, just increased cost. So in general, it's important to remember gram-negative bacteremia in particular, when treated with a second-line beta-lactam, is associated with a 10% risk of treatment failure from another study. So when we use those second-line therapies, they just don't work as well. But there's been some great updates. In 2022, the college, we call it the College and the Quad. So there are two of our academic scientific groups. They came together to release a practice parameter that had a couple very interesting and very pertinent for allergists and non-allergist updates. The first was to prioritize risk stratification over skin testing in low-risk patients, and to do proactive penicillin delabeling as much as possible. So seeking out patients, even when they weren't coming to us for a penicillin allergy issue, seeking them out to delabel them, and then also doing direct challenges for cephalosporins when there was a non-anaphylactic initial allergy. And I'll give you some more updates on how exactly that part works too as we talk through. So stepping back, what can we all offer patients with a beta-lactam allergy? First step is risk stratification. And from there, eliminating false allergy labels, guidance on appropriate drug avoidance, and also drug challenges as well in the right cases. I always say that. So let's talk through some of the risk assessments. It's important to recognize that there's a spectrum of adverse drug reactions overall. The IgE-mediated reactions will occur within minutes, not so frequently hours after exposure. Most of the time, it's characterized by hives, swelling, passing out, vomiting, trouble breathing, or asthma onset. And you can see that these are usually very well classified and pretty quickly treated. Best treatment is always going to be an EpiPen. And that's something that I always want to encourage us all to remember outside of allergy too. But you'll see that there's this great timeline, and this was shared in the practice parameters for a lot of the other types of drug effects. And many of them are delayed by hours to weeks, which can make it our jobs difficult, but also part of the reason why I like to do my work. But it's important to recognize that many of these other types of reactions can be classified as allergies, can be classified as hives, even though they were eruptions or other types of rashes. So it's always important to have it on your spectrum of your radar that these could be reactions that are kind of masquerading when a patient says they have an allergy. What are low risk reactions for which you should not hesitate to challenge? And the reason I don't say just remove the allergy label is in general, patients need sometimes the supportive, this more like the anxiolysis of saying, hey, I took the first dose with a provider and I was monitored and it went really well. That type of allergy removal actually does a lot better and is much more stable and much more durable in their chart in their long-term history than just removing the allergy label. So the first one is if they tell you the family history. We can't actually inherit IgE-mediated allergies. We can inherit a higher risk of having allergies. So you will see families that all have allergic rhinitis or all have asthma or eczema, but they can't individually inherit an IgE-mediated reaction. Each immune system has to form that reaction. Also, if they report headache, isolated diarrhea without kind of other IgE symptoms or bloating, in general, I would say if you can get them to stick with you and do a challenge, a one-step challenge, or their first dose is a challenge with you in the clinic, that's going to go a lot better overall. So perform that challenge and then remove the allergy label. Always an important step. Don't let them get out of that visit without taking the label out of their chart. So let's talk about the best risk assessment we have out there. Well labeled as called the PenFast score. You give 2 points if it's been 5 years or less since a reaction, 2 points for anaphylaxis or angioedema, 2 points for a severe cutaneous adverse reaction, anything blistering or peeling or scary sounding like the Stevens-Johnson type of symptoms, and then a 1+ for treatment required for that reaction. And this was derived from about 1,500 Australian patients reporting a penicillin allergy. Low risk means they have less than 3 points, so 0, 1, or 2 as a score. And that is a negative predictive value of 96%. That's pretty good. So that meant that in their challenges for all the patients that they could, only 6 reacted during an oral challenge, or 3.7% had a positive allergy test in the form of an oral challenge. It's a pretty good test. It'll work really, really well. And it continues to be well validated. In a recent study in Ottawa, they performed 200+ low-risk challenges, so scored for anyone 0, 1, or 2, and they had no adverse events, which was spectacular. And those patients went on to tolerate and receive beta-lactams more frequently than their non-challenged peers in the next 6 months. And they only followed for 6 months because that's what was the limitation of their study. So who should perform these risk assessments? There's a recent consensus group called the Hong Kong Drug Allergy Delabeling Initiative that was a Delphi consortium review of from allergists of how best to delabel their penicillin allergic patients. And they realized that the time to allergist assessment could be as long as 16 months in their group, and it was less than 6 months for non-allergists. So they were using a hub and spoke model where the spoke were non-allergist assessments, and if there was anything like a higher risk, they would be referred to the hub center. And they importantly excluded pregnancy, immunocompromised status, chronic urticaria, and the inability to hold interfering medications such as antihistamines as a reason that they should be excluded from that type of risk assessment. So those are important things to kind of hold true when you do risk assessments. But that overall, they thought an oral challenge and usually delabeling by a non-allergist was the best option for low risk patients. So any provider can administer a risk assessment and then a low risk challenge. And again, that's for pen fast less than 3. So these scores, the pen fast scores and the one I'll talk about next, are best again for the IgE mediated reactions, although they do include the scar reaction. And it's important to recognize if anyone does have anything that looks like a blistering rash, a Stevens-Johnson syndrome rash, their history will always get them a score 3 and above. So they will have the blistering reported and they will usually need a treatment, which will exclude them from anything low risk. But it's important to recognize that we don't ask in that questionnaire because these reactions, including fevers, serum sickness, interstitial nephritis or drug-induced liver injuries, and AGEP, acute generalized exanthematous pustulosis, are excluded from the screening because the screening is really best to keep the Stevens-Johnson's patients safe and also those recent anaphylactic patients safe as well. And recently, the CEPH-FAST score was presented at our most recent scientific meeting, and it was well validated overall. So use the same criteria as PenFast, but it's meant to be applied to cephalosporins as well. So it was created from a smaller cohort. There just hasn't been enough time to do as many studies yet. It was Australian and American cohort of 395 patients total. They didn't need to do adjustments because they were looking to make sure if there were any breakthrough, increased level of severity. And for a score 0, 1, or 2, so less than 3, they only had 5.7% positive results of allergy testing, which ended up being a very close 94 versus the 96% from earlier. So what about safe avoidance? When you do find out that someone has those higher levels of risk, so when they're score 3 and above, what choices can you make to help out in terms of recommending medications and still being able to get very targeted therapies? Let's talk through a quick case because I always want to remind everyone of the spectrum of what things can look like. There's a 79-year-old male. He had poorly controlled COPD, multiple antibiotic-treated exacerbations, and he came into his primary care office to treat a gluteal abscess. 10 months before, he'd become pre-syncopal. He'd felt like he was going to pass out when he was injected with cefepime for one of his COPD exacerbations. And he's treated with intramuscular ceftriaxone for gluteal abscess, and within minutes of the injection, he dies. Post-mortem, he was found to have an elevated tryptase, and anaphylaxis was determined to be the cause of death. Could this death have been prevented? Unfortunately, yes. As a background, though, this did end up going to trial, and it was determined that the level of specific knowledge was too high, and the primary care doctor was not charged. So this case is why we should worry about beta-lactam cross-reactivity. So the R1 chains over here, this is the penicillin structure, cephalosporin structure, monobactam, and carbapenem. The R1 chain, we think, is the primary aspect that mediates this cross-reactivity among penicillins versus cephalosporins, and even among the many generations of cephalosporins. So what about monobactams and carbapenems? We've seen overall that, again, aztreonam is proven safe for penicillin allergic patients, and only in one specific case. So if they have a ceftazidime sensitivity, hypersensitivity, those patients have been seen to react with aztreonam, but that's the only case to kind of keep in your mind overall. And I wanted to share a cross-reactivity chart that I use. And this is one that came from where I was in training. I helped out with making it, and our goal with creating this chart was to be as clear as possible in the sense of starting with the early penicillins, first generation cephalosporins, and working down in terms of kind of the timeline of the development of these medications. But then also, this is specifically tailored to the formulary at Northwestern currently. So if you don't see a medication on there, it's okay to ask for help or to look at other cross-reactivity charts as well. What I like about this chart is that the X's will represent those R1s that are the same, and it also represents some R2 side chains. And the yellow triangles are when there's caution or there's less likely because the side chains are only similar. Stepping back, the data on these sorts of charts, and there are a plethora of them. Some are color coded better than others. I will always say that. And so I always want to make sure you find one that works well for you and that gives you an easy way and quick way to read things overall. But the data behind these are not perfect. So we can't always know exactly what will be a reactive, a cross-reactive option for a patient. But most of the time, this holds true based on that R1 cross-reactivity chain. So what happens when we've selected an option, we've done our risk assessment, what do we do next? Well, 90 to 95% of time, reported penicillin allergic patients will do really well with the challenge and not have an issue. But what about that 5 to 10%? I always want to talk about that so you kind of know what happens or what to do if you do a challenge and something isn't going well. And then also what we do as when we're challenging in the office as well. Again, they're not without risk. It's something we do only when it is the only treatable medication, the best treatable medication, when the patient doesn't have excellent alternatives that they aren't able to tolerate well, or in the case of sepsis, bacteremia, or very targeted infections. We don't do drug challenges just usually unless they absolutely need it or unless they're very, very low risk. So this was a great study that came out of the MGH. It was 1,000 plus test doses in about 942 patients across 5 hospitals. And it wasn't only low risk patients. So it was just all the challenges they'd done. And they were largely done at academic sites by house staff and usually in internal medicine. And there were 78 adverse reactions. 40 were immediate IgE-mediated hypersensitivity reactions, so a reaction rate of 3.8%, which is kind of going, we see usually somewhere in the 5 to 6 to 4% rate of reactions. Kind of they slip through, the body is held on to that allergy. And then there were 38 non-hypersensitivity reactions. Some were somatic symptoms, intolerances, or toxicity reactions. So this was going through, and the non-severe cutaneous reactions were things like itching, a rash, hives. The rash, the hives are tough. Rashes, again, are, I would say, delayed drug allergies, and the rashes that go with them are some of the harder part for us to be able to treat because we don't have the options of doing desensitization for delayed reactions. There is no option to do a desensitization for things like SJS, TENS, fixed drug eruptions, AGEP. We just have to avoid and really recommend good cross reactivities. So it's a thing that I want to point out that most of the time when we're hoping that a reaction has gone away, it's usually a delayed T cell mediated reaction that is still going to pop up over time. Then for severe IgE-mediated reactions, there were 10 or about 25% of the hypersensitivity reactions. These patients had wheezing, they had swelling, they were ready to pass out or had low blood pressure, and then one was classified as true anaphylaxis, so meaning multi-systems instead of just one isolated system. And then 3 were severe delayed. Acute interstitial nephritis was one of those. One had a scar resurface, and then one had AGEP appear. And AGEP is that reaction that looks like pimples all over the body, usually on the trunk, spreading outwards. And it's important to recognize that that reaction can have a 5% chance of morbidity, mortality associated with it. So even though it doesn't seem like a scary reaction, it isn't usually billed under the severity as much as scars or those severe cutaneous adverse reactions. It is important to still avoid for something if you see AGEP labeled along the way. And what was the reaction treatment? Luckily, again, 60% of the patients did not need any treatment. 40% got antihistamines, some got steroids, and only 8 got an epinephrine dose, which is something that I want to point out that I deeply appreciate how brave NGH was in sharing this information. It's not always easy to share that we don't, as providers, do a great job in treating early when there is a IgE-mediated reaction. And the best treatment, the first treatment, shouldn't be antihistamines, shouldn't be steroids. It should always be intramuscular epinephrine, ideally into the thigh muscle, into um, the quadriceps muscle. There are some studies that show that administering intramuscular epinephrine into the deltoid or into the triceps is more delayed. So it's always, I think, an important part to recognize that the best first thing is intramuscular epinephrine, and then you can figure out other aspects along the way. But I deeply appreciate that this is real world data in the sense that this does represent what we see of how reactions are treated, because it's hard to recognize what anaphylaxis is when it's slowly creeping up overall. And then it's interesting that they weren't able to see if there's any treatment given for up to a third of these reactions as well. So overall, rates are low, most reactions are mild, but severe can occur, and it's really important to do that timely and appropriate treatment. So I'd love to talk through some cases. And this is our first one. A 34-year-old female comes in for an annual exam. She notes that her mother told her that she had hives after taking amoxicillin when she was 2 years old. So it's been 32 years since her initial reaction. She heard on a recent podcast that she might actually not need to avoid penicillin. And this is a real life reference. So Kim Blumenthal, who's an excellent advocate for beta-lactam allergy and working to really promote the early delabeling of patients who are safe to delabel, did speak on Freakonomics Radio recently. And I hope you all can take a listen to the podcast too if you have time. So this patient now asks, how can I tell if I'm still allergic? So we have three options for answers. I'll let you scan the code. So what is the best next step that we can take for this patient? A, refer her to an allergist for skin testing and evaluation. B, ask her to continue to avoid all beta-lactams. Or C, perform a pen fast. I'll give you the score. Her score would be 0. And an oral challenge to amoxicillin. I'll let you all scan in, or if you're still got it pulled up on your smartphones.
Oh, it's not
Perfect.
advancing, or at least,
Oh,
oh, it didn't
there we go. I
let
had
me
to,
in.
sorry, switch over and it should be, okay, perfect. So we're seeing some answers pull in. Thank you for letting me know that along the way too. Great. I'm thrilled to see your answers. I hope I didn't make it too obvious or too easy along the way, but this does make me happy. Um, Again, the reasons not to do skin testing are always going to be that it'll be a delay in treatment. It's going to potentially make the patient think that her reaction is worse than it is another interesting way that if you're uncertain or you feel unsafe about it, I think it is always safe to ask for help. But in these reactions, if you have the PenFast score to really support your decision making, it is always a good idea to be able to offer that challenge in clinic too. All right. So again, correct answer would be the PenFast score, and I'm thrilled to see your answers there too. So how durable are these removals? Unfortunately, penicillin allergy removal is like a game of whack-a-mole. And I'll walk through a study that kind of demonstrates this overall. So in 81 patients that had their penicillin allergy removed, 62 had the allergy not reinstated. So 77% excellent. They were able to keep it. But then 19, or about a quarter of them, had the allergy reinstated. And these patients were followed for about 8 months after their initial removal. And the median time to reinstatement was only 90 days, only 3 months later. And it was reinstated both for inpatient and outpatient settings. And then multiple team members were the part of adding it back in. And what was interesting was only one acknowledged that the allergy label had previously been removed. But in 94% of them, so almost 95, they didn't even acknowledge this patient had previously had their allergy removed. So, and only one patient had an adverse reaction that would have triggered the replacement of this label. What we do in clinic is we provide a drug pass letter that says you had this testing performed in clinic today. We no longer think you're allergic. You were able to tolerate this challenge. And we ask patients to bring it to their pharmacy, bring it to their primary care, and especially emphasize to them that for electronic health records, the records will always err on the side of promoting and supporting that allergy label sticking around in the chart, which makes our jobs difficult, but is a good safety option because we don't want to have things missed or lost over time. However, when we safely delabel them, we like to also add a label into the electronic health record that says this challenge was done on this day in an allergy office and we removed it based on their tolerance so that there's as much detail as possible as to why this allergy label can be removed. And if you're doing challenges for low risk patients, which I always will encourage you to do, I please ask you to add that type of labeling, even if you don't need to or are able to generate a drug pass letter for the patient to carry with them going forward. So let's talk through another case. A 73-year-old male presented for a shoulder joint replacement. He reports that about 3 years ago, he had hives, difficulty breathing, and vomiting while taking amoxicillin clavulanate for a sinus infection. He needed to call 911 for this reaction, and it was treated with intramuscular epinephrine. So, breaking down his PENS-FAST score, he had a recent episode. He had anaphylaxis. I always want to be very, very clear that multi-system involvement is always anaphylaxis. It was not a scar reaction, and he did require treatment, so his score is a 5. What perioperative antibiotic would be the safest and most effective to prevent a surgical site infection for him? So let me hop over to the next question. Our options are aztreonam, vancomycin, or cefazolin. I think we've got at least 9 participants, so I'll give you all a little bit more time. Great. So I love to see this. This is great. So let's talk through this a little bit more. I love to see that we've got some different answers along the way. The answer is cefazolin, and let's talk through why. Cefazolin is very, very, very unique. It doesn't share any R1 side chains with any other cephalosporin or penicillin, monobactam, or any of the beta-lactam allergy family. So it's actually, we think, uniquely safely profiled to be well tolerated. And this is supported in our drug practice parameters from 2022. So if a patient comes in and reports anaphylaxis to penicillin, as was reported for this patient, they have a high PENFAST score, then cefazolin utilization is still okay because it would be a non-cross-reactive cephalosporin. I would say it is probably the easiest information to carry with you that cefazolin is unique. And that is, I will admit, the amount that I can memorize for beta-lactam cross-reactivity. The rest of the time, I will go and reference my chart to help guide myself so I'm not making mistakes. And when you don't do the drug allergy work all the time, I think that is probably the easiest thing to carry with you. For a more delicate answer, if the patient comes in and reports anaphylaxis to any cephalosporin, then cefazolin testing plus or minus a drug challenge would be the next recommendation. The reason we still want to promote cefazolin in this case is that using vancomycin, using aztreonam, they work. They're options, I would say, but they aren't the best option to treat surgical site infections and many of the other infections that cefazolin is best at preventing or treating along the way. So then let's talk through another interesting case. We talked a little bit about how carbapenems, aztreonams are a little bit special. But again, if a patient reports penicillin or cephalosporin anaphylaxis, carbapenems are okay to use. And that's why we can choose those along the way. And if penicillin or cephalosporin allergy except ceftazidime, that special case, then aztreonam is okay as well. So this information gets very nuanced very quickly. I'm happy to share this slides with you, happy to share the links to the drug allergy practice parameters. but it's hard to dig through them on a regular basis. So I think the safest and easiest way is to have a preferred cephalosporin beta lactam cross-reactivity sheet that you can reference when these questions come up, and to use your CephFast and PenFast scoring to help decide what you would like to use as a next step. Right now, cefazolin can't be recommended if there is a cephalosporin anaphylaxis, but I think that information is has an opportunity for change in the upcoming future. We just, in the upcoming years, months, maybe even, but we just don't have enough data to be able to blanket statement recommend it at this time. I can tell you anecdotally for patients with cephalosporin allergies and anaphylaxis, I've seen them tolerate cefazolin when it's given in, you could say, technically an accidental way, but it's not something that yet can be blanket statement guideline recommended. So, stepping back, my big take home from today would be please don't use non beta lactam antibiotics in patients with a history of a penicillin allergy without an appropriate evaluation. And this is a statement that came directly from Choosing Wisely. I believe this is a 2020 even or earlier Choosing Wisely campaign, supported again in popular culture, supported through the American College of Asthma, Allergy, and Immunology, as well as our main scientific body. And then also these statements are additionally supported by the Infectious Disease Society of America and the Society of Hospital Medicine. So it's not easy to make these changes in your practice. It's not easy to ignore sometimes years and years of how we've tried to keep patients as safe as possible. And so if you have questions, I'm always happy to help out with things as they come up along the way. And I know that it might be hard to access allergists throughout the state overall, just because I know we're usually more concentrated in urban areas and also not as often available for inpatient questions along the way. So I'm really happy to help too right now if you have any other questions or specific cases you wanted to talk through. And then I'd love to just open the floor for other questions along the way too. And I'll stop my slide share here and then hop back into, let's see, the Zoom. There it is. All right.
That's
Perfect.
disturbing.
All right. I would love to hear any questions that you all have come up with. This, I hope this was also open your minds to some new options for how you can help your patients out directly. And I will say, I always feel bad saying, hey, I can't do every part of my job. I can't go in and do the low risk assessments every time, but just with how many people, so again, we have 340 million people about in the US right now. That's at least 34 million people reporting a penicillin allergy. This is a job for all of us to be able to help out with along the way.
And Katie, I have to really thank you for presenting this information. I will say just from anecdotes, I I think I see somebody with a PenFast score higher than two about one out of every 20 or 30 patients. It's very rare.
That is encouraging. Most people are going to tell you that story like my first case that, I got really sick. And I really want to encourage you. People will say initially, I don't know what my reaction was. I don't know what happened. But they can't answer yes, no questions. They can't say, yeah, I wasn't in a burn unit. Yeah, I didn't have blistering. Maybe I didn't need to go to the hospital. And, I was just told I shouldn't do it again. That really lowers their score. And although the PenFast score does allow for an unknown, I don't know if it's always the best utilization. I think that most people, when you press them a little bit further, and we all have limited time, we don't have a lot of opportunity to really sit down and do this assessment on a regular basis, um, just because there's so much pressing us in clinical medicine to deliver care quickly, but it can make a big difference to be able to clarify that information. And it helps us too. When somebody comes to us with a higher risk score in advance, we can kind of prioritize where we put them in the schedule. We could move them up faster. It helps everybody out.
Katie.
Oh, hi,
Great
Helen.
talk.
Thank you.
I love working with you. I'm so
Hmm.
lucky. I was wondering the Cephas score. I'm sorry, I had to step away for a call, but so I might have missed it. Is that ready for prime time?
It isn't, well, PennFast has never been anything more than just validated in papers. So
Oh,
I would say that Cephas is probably in its like first lap around the track right now. Um, Much of the way that we assess our patients is based on that type of criteria. So I would say, as an allergist, based on, again, it was a smaller number. So again, around 400 people assessed versus the 1,500 used for PennFast's initial publication. And Cephas hasn't been officially published as its own paper. It's just been an abstract. But based on how we do allergy history for beta lactams, I would say it makes a lot of sense to start to initiate it because it can help us rule in or rule out severity overall. That's a great question.
awesome. Thank you.
We have a question in the comments that asks, can you clarify the statement in your slide? If penicillin or cephalosporin
Oh,
except
yes.
ceftazidime, then as trio, okay?
Yes. So if anaphylaxis to penicillin or anaphylaxis to cephalosporins, except anaphylaxis to ceftazidime, then astrienam will be okay to use. So ceftazidime does share an R chain with similarities of an R chain with astrienam. So if your patients have had anaphylaxis to ceftazidime, you would need to avoid astrienam. Does that help? That's a great question. And this is what can make memorizing that chart so difficult. And if you need a quick link, I will admit, every time I'm like, wait, can I give this cephalosporin? I just Google NM ADSP and I'll pull up this website that has the chart on it under the allergy resources. And I'm sharing that here. Um, and then I will also ask Erin if I could share my slides with you for the group as well.
Sure.
The link is in the slide page as well.
Okay. I am recording this also, so it
Excellent.
will, I don't know the time frame exactly, but eventually it will make it onto our MASEC website as well, so people will be able to rewatch if they want to,
Mhm.
or share
And
it with
that's
their
a great
friends.
point that IDSA does have a chart as well. There are many options out there. I've become familiar with the other one, but you find the one, please, that works well for you. In general, they'll usually have more safety data than less. So I wouldn't say there's an unsafe one out there unless you don't see enough cephalosporins that are modern represented. I find that color coding and printability are two of some of the easiest parts, which again are not medical knowledge related, but there's some of the parts that can make reading that chart a lot easier or a lot harder. My question that I wonder about for everyone is, do you have access to allergists in your local health systems? And I should have included that one as one of my questionnaires. I will remember that for next time.
Got one response that says no
Mm.
allergist connections.
Hmm. Um, we're always happy to take referrals. I run a drug allergy clinic with my colleague Jen Monroy, who has presented to this group before. And our nurse practitioner, Christina Skinner, manages all of our drug allergy referrals as well. So if you do have anything that gets more complex, those higher PennFast scores, higher cephalosporin assessments as well, I would love to help out with them. We are able to do a lot of challenges, a lot of intradermal testing, a lot of testing that can be difficult for many outpatient allergists who don't have access to a pharmacy to be able to perform. And it can really help to guide patients' next steps, especially immunocompromised patients, pregnant patients, and patients who have recurrent infections of any variety. Um, it's it's not easy to get um, access to a lot of the things that we have. And so I'm lucky to work in this system. How do I get providers to buy into doing challenges? That is a great question. I get to talk to you all, and hopefully someone will feel comfortable to do some of the lower risk ones as well. It's something that we're working with our residency group as well to promote, and it's a very early step. And I'm also working with Helen to really started like a baby steps into seeing what patients can report to us in advance to be able to score PenFast scores. There's many groups across the US that are doing these types of initial assessments. Some of them are using um, like metrics within Epic to perform the PenFast scores, but we're often limited when patients have provided or received care outside of our individual health network, that we can't pull that data as easily into safety assessments or best practice guidances. And so my goal is that we make it more commonly assessed as part of an annual physical exam. And that's something that CMS has begun to promote as well as part of the annual visits. But it takes time, I would say, and it takes comfort level and doing a couple challenges too. As a case, I recently had someone who I do not think has a true allergy. I did penicillin skin testing on them because they were anxious more than because the guidelines would direct it or because they needed that skin testing. And within 25 minutes of their first dose, we usually do a dose challenge as an initial 10% of the dose and the remaining 90% of the dose split up over 20 minutes for the first 10%, followed by 60 minutes of monitoring for the second dose. And when we were doing the first dose, she said she was itching, no hives, nothing going on in terms of my skin exam, no change in vital signs. But that was someone who said, I can't keep doing the challenge. I don't want to get it done. And they are the perfect case for why the challenges are frequently best done with a provider in mind, because if she'd done that first dose at home, she would say she's still allergic to penicillin. But I can say, hey, it sounds like today wasn't the best day to do this challenge. Looks like you're rushing to get to work after this. Why don't we try this again the next time you come in? And that's our plan for her overall.
So I have found just discussing with our internal medicine hospitalists that the PenFast score actually helps a lot in getting providers to agree to primarily dose challenges. Um, it, I think a lot of people just have a very difficult time sort of uh, grading risk for penicillin allergies. Physicians too. And with a something that is slightly more algorithmic, where you can say this is 0 to 1, this patient is very, very low risk, it makes them a lot more willing to then be, just either try a full dose or at least try a test dose, um, as opposed to uh, you know, always thinking that a person needs to be either fully desensitized, which is a kind of ridiculous thing to undergo for a non-allergy, or a skin test, which is also complicated to arrange even in an academic hospital.
Mhm. It is difficult to be able to provide skin testing on a timely basis, just because we as allergists are based outpatient and at satellite sites, and so for us, it's quite difficult to be able to get in and read and perform and administer a challenge. We're lucky to have a training program, a fellowship program where the fellows are there to help work with us on site. But I think the drug practice parameter's biggest input is that skin testing is not the most effective method. Um, there's also some recent studies, and I didn't include this one just because it's interesting that we do see false positives for penicillin skin testing. And intradermal testing does take a lot of time and expertise to be able to read over time. Um, it is interesting how even when you introduce saline under our skin, we can still have some redness. And so you can have a lot of people who will say they have a positive result, but it's actually just the kind of irritation of having something go under their skin. That's why excluding people who are having chronic hives from this evaluation is very, very important from a safety perspective because they are at risk of having more of those urticaria angioedema type of reactions, but then also because they can have what we call dermatographic responses, meaning that even salt water will trigger people to look like they have a hive response. And so skin testing comes with, I would say, much exposure and much expertise to be able to perform correctly, especially for those higher risk patients, which is why I will always welcome those patients into our clinics to be able to help out with those assessments. And the lower risk patients really do benefit from, I think, Kevin, you couldn't have said it better, the algorithmic comfort of knowing, hey, there's a really low predictive value that something will go wrong. And doing those first challenges in a medical setting of any variety, whether inpatient or outpatient, is always a good option. Especially, again, low risk is the way to go.
And I think probably most people here have had at least one incident where somebody has complained about a reaction to not having actually gotten a medication yet. An injection of saline, um, just flushing the actual line, or maybe just the line insertion itself. And they complain that something is happening to them, and that's very unlikely, if not impossible.
Mhm. I think that it is amazing how much our minds can work against us when we're feeling unwell, and so I always want to give those patients um, so much room for understanding too along the way because people are feeling really, really sick when they get to see you or they get to see me sometimes more often when they get to see you.
Any other questions? All right. Well, it is 10 or a little less than 10 minutes before the hour. And so happy to give people back a little bit of time on a nice day. Thank you all for being here. We're going to be trying to do this regularly, not at an incredible frequency, but regularly, so that we can keep everybody up to date with issues regarding antimicrobial usage and antimicrobial stewardship. Thank you all, and we'll see you then.
Thank you.
Bye.